Hello, friends in Florida. My name is Patty Lee King, and I'm the State Project Director and Quality Lead for the Illinois Perinatal Quality Collaborative. I'm really thrilled to be a part of your FPQC Postpartum Access and Continuity of Care Initiative kickoff. FPQC has been a part of our ILPQC journey from the start, and so you're all like family to me. I'm so sorry I can't be there in person. I always welcome a trip to Florida, but especially as the chill creeps in the air in Illinois, which it certainly has this week. But great minds think alike, and we're currently hosting our 10th annual conference in person after 2.5 years of virtual gatherings. So I hope you are enjoying your time in person together while we are as well. So I'm excited to share with you what we've learned in Illinois from our Improving Postpartum Access to Care initiative, with a focus on what worked for our hospital teams. I'll work hard to keep this recorded presentation engaging as you enjoy reconnecting in person today. So the ILPQC Improving Postpartum Access to Care initiative, which we call IPAC, worked to implement guidance from the ACOG committee opinion that redefines postpartum care as an ongoing process to optimize the health of women and infants, with a focus on all women having contact with the maternal care provider at a 2-week maternal safety check. And we included several aspects to that maternal safety check as outlined in the ACOG committee opinion. So blood pressure check, wound perineum check, breastfeeding support, mental health and wellness checking, and family planning, and contraceptive counseling, with follow-up and ongoing care as needed. And concluded with a comprehensive postpartum visit with a full physical, social, and emotional well-being assessment and about 6 weeks postpartum. So ILPQC's IPAC initiative aimed to, within 12 months, have 80% or more of participating hospitals documenting and offering a universal 2-week early postpartum visit scheduled before delivery discharge to optimize the health of women by increasing access to early postpartum care within the first 2 weeks postpartum, and to improve postpartum safety education. In addition, some specific goals were to increase the percent of women with an early postpartum visit scheduled with an OB provider within the first 2 weeks after delivery, to increase the percent of women receiving focused postpartum education prior to delivery discharge, and then to increase the percent of providers and staff receiving education on optimizing early postpartum care. So this is an initiative that had 16 Illinois birthing hospitals participating, and this was between May of 2019 and May of 2020. And they were working on implementing key QI strategies to improve postpartum safety. So the map shows kind of the representation of where those hospitals are located in the state of Illinois, with good geographic diversity. And on the left side of your slide are those key strategies to improve postpartum safety. And so they included utilizing a provider outpatient packet, which was really our beginning steps to help hospitals engage OB providers and outpatient care sites to help plan for early postpartum visit scheduling, obtaining buy-in from providers, and sharing options for billing and coding. So really engaging the hospital teams in strategies to engage all their OB providers, even outside of the hospital, something that we've been doing since and has been a helpful tool for teams. The second key strategy is about implementing process flow to facilitate universal scheduling. So really the idea here is understanding what your current systems are for scheduling and discharge, and making sure that you're adapting them, changing them, testing them to include the important components of this initiative. So this was really making sure that the visit got scheduled universally for all patients. And then the third is to implement provider and nurse education. And this is on the risks of postpartum period, benefits of an early postpartum visit, and key components of the maternal health safety check. And then the fourth strategy was on patient education. It's a standardized system to provide patient education prior to hospital discharge. And that included the benefits of early postpartum visits, how to identify postpartum warning signs and seek care, and the benefits of healthy pregnancy spacing and options for outpatient planning, outpatient family planning. So hospital teams used the ILPQC data system to facilitate their QI efforts. The hospital teams, in this diagram shows that it's kind of the process, and we'll get some animation there. So the hospital teams collected data through chart review, and I've highlighted this first graphic here as an example of a paper electronic printable form that teams can use to track their data and enter abstracted information into the data form. The second step is that the hospital teams had entered the data they collected into the ILPQC data system. And then finally, they get back reports that allow them to look at their progress over time and in comparison to other hospital teams. For this initiative, we did a sampling approach to data collection, knowing that this initiative applied to all births, and for most hospitals, providing data on all their births as a separate process would be a burden that would be untenable. So we instead used a sampling approach. So each team participating in this initiative collected a random sample of 10 delivery charts per month, and they reviewed them for key measures that we collected. And this led to a total of about 2,500 deliveries being sampled across the collaborative from the baseline, which was measured in the Q4 of 2018 before the initiative started, so retrospective data collection, to the Q4 of 2020. So the rest of this talk is focusing on strategies and lessons learned to, I hope, be helpful in your implementation of an initiative to improve postpartum access to care. And it will include examples from our hospital teams. I intentionally kept the overview of what ILPQC did brief. I'm happy to answer questions. I can give you my email address, or FPQC can share with you if you have questions about our initiative. But you'll learn more about it through these examples nonetheless. So hopefully you'll leave with all the things you need. So first we'll look at strategies to help facilitate early postpartum visit scheduling by hospital teams. And we're going to start with some data from our collaborative to show you what we were able to accomplish, what the teams did, and then also have some examples from our hospital teams about how they did it. So clinical team buy-in comes up as a key strategy across our initiatives. I'm sure you run into it in your work as well. And it's an early and often type of issue that hospital teams are working on. So buy-in, a lot of energy early, but never really, the need to focus on buy-in among the clinical team never really goes away. This graph is shown in a format borrowed from FPQC, the percent of hospitals that have implemented the structure measure of communicating recommendations and strategies for early postpartum visits to obtain buy-in over the course of the initiative. So this is where we asked hospital teams to have a process to make sure that they were communicating the initiative and the background information and the why to all the clinical teams to make sure, to team members, to make sure that they knew the reason for the initiative and the why we were doing it. So you can see that compared to baseline, by the end of the initiative, the green portion of the bar is the percent of the hospital teams with the structure measure in place. So the systems change has been in place. Yellow is something that they're working on, and red means they haven't started working on it yet. Teams focused early on buy-in, as you can see in this graph, and all teams by the end of the initiative had communicated recommendations to their clinical teams. So this is a great way to look at data. I think FPQC every day for it. We use it a lot to really understand not only how you're doing it overall on a measure, but how many teams are achieving the goal. So this graph shows progress on another structure measure by the percent of hospitals that have a system in place to facilitate scheduling early postpartum visits over time. So again, green means the measure is in place. So here as well, early postpartum visits weren't a thing among our hospital teams at the beginning, at baseline. And then at the start of the initiative, they were actively working to get a process for early postpartum visit scheduling in place. So finally, some outcome data on this point. Did we actually accomplish the goal? So this is a graph of the percent of patients with early postpartum visits scheduled prior to discharge. This is not a structure measure or systems change where hospitals go in and say where they're at with it. This is actually based on that random sample of charts. So we can see that we had 7% or less of patients during those 3 baseline months having an early postpartum visit scheduled, to over 90% of patients being scheduled for an early postpartum visit by the end of the initiative. So what do the hospital teams do to achieve the goals and accomplish what I've just shared? So hospital teams first focused on developing a process flow for scheduling early postpartum visits. And I outlined that as one of the key strategies, as a second key strategy in the list I went through. They used PDSA cycles to test and change their processes to best achieve the goal of scheduling early postpartum visits universally for all patients. So here's an example we shared with hospital teams. We shared examples throughout the initiative to really help them kind of have a concrete understanding of what the goal was of the process flow. And this includes patient counseling on the importance of the early postpartum visit at 2 weeks and education on the benefits of the early postpartum visit, maternal warning signs and pregnancy spacing, as well as logistics to schedule the appointment and make sure it's documented. So this is really what our team spent most of their early time really focused on: developing, testing, improving until it was ready to implement. So I promised hospital examples, and I was lucky to have 3 hospitals that shared some specific things that they did to implement this work at their hospital. So how did hospitals secure buy-in, develop a system to schedule early postpartum visits, and get patients scheduled? A hospital in Chicago, this was a Chicago hospital, had about 1,000 deliveries per year, worked to schedule early postpartum visits. And they had a process in place before the start of the initiative for all high-risk OB patients to be scheduled for a 1 to 2 week visit. But during the course of this initiative, they used a 24 to 72 hour discharge phone call as the time to confirm the 2 week appointment. So they used an existing step in their process flow to add this task. They also partnered with a home visitation program where about 45% of the patients opted in to the home visitation program. So of their birth population, a significant portion does the home visitation program. And the home visitation program was another place where that 2 week visit was confirmed. So partnering with organizations to help make it happen. They also developed a smart phrase. It was IPAC or IPAC declined on the after visit summaries to add the appointment dates and document and track the 2 week visit scheduling. So another hospital, this one's in Southern Illinois, really serving a large region, given a lack of other accesses to maternity hospitals in that area. It's in the center or south of Illinois. And if you know Illinois, I don't know if it's as long as Florida or not. Actually, my geography is rusty there, but it's a long state. And this is an area where there is not a huge population and it's very dispersed. So this Southern Illinois hospital has about 2,000 deliveries a year. So again, this is reaching a large geographic area. Worked with a patient navigator. So they used an existing piece of their system, a resource to implement this work. And the patient navigator helped schedule the 2 week visits. So between Tuesday, there was a big discussion on our teams about the weekdays versus weekends, discharge and navigating that. So in this case, Tuesday to Friday, the discharge navigator, patient navigator calls the office to schedule the appointment for 2 weeks for the patient. And Sunday through Monday, the staff notify patients to call on Monday for a follow-up appointment within 2 weeks. So they had a process in place to help them navigate both weekday scheduling and weekend scheduling when the office wouldn't be open. And then finally, here's another hospital. It's Chicago region, but very, very far south, not in the city of Chicago. It's a good, hour and a half drive past the city of Chicago in the south, far suburbs. So this is a hospital with 80 to 100 births per month. And the majority of patients that they see come from a local community health clinic. And they worked with that clinic, again, leveraging existing resources to change culture among their clinicians about 2 weeks for everybody and making it routine for all routine patients. as well as working to develop buy-in with the clinic where many of their patients come from for delivery, where those office personnel from the clinic would come into the hospital every 2 to 3 days and schedule 2-week postpartum visits with the patients. So I hope those examples were helpful. I'll put feedback on some of the other strategies that they shared throughout the slides. But ultimately, with the goal of making sure that teams were scheduling for all patients 2-week postpartum visits before discharge, within 11 months of the initiative, all of our teams were doing that. And that's something to celebrate. And I know you'll look forward to that celebration as well. So in addition to celebrating that teams were implementing it, there are other initiative benchmarks we looked at, right? How many patients were scheduled, how many patients got discharge education on the different topics, so birth spacing, early warning signs, and the importance of the postpartum visit, early postpartum visit, I'm sorry. And we found that hospital achievement of these goals didn't vary by their hospital location, birth volume, or patient mix. So we were able to, see success in achieving all goals across all of the hospital teams. So now we'll look at strategies to facilitate postpartum safety education for providers, which was another key piece of this work. Here again on that graph of a systems change or structure measure, as we call it, shows that all participating hospitals in this initiative were able to put in place a system to educate inpatient providers and nurses on improving postpartum care by the end of the initiative. So again, where things almost didn't exist at the beginning or before the initiative, they were in place across all hospitals by the end. And then on the actual process measure, what percentage of providers were educated. We can see here the percent of providers educated on optimizing early postpartum care over the course of the initiative went from almost no providers being educated on these topics to 90% by the end of the initiative. So how did we do this? Again, what's the how? The OB provider packet was a really big piece of what we did. So this is a toolkit where we had toolkit for hospital QI teams, but then really made a set of resources specific for OB providers that may or may not be directly engaged with the QI team, really making it ready for kind of quick implementation. So it included a letter signed by the hospital OB chair to communicate to all OB providers that deliver at the hospital about the initiative and the specific goals and work of that QI team in that hospital. That also included the hospital discharge process flow, so expectations for communication and tasks in that process, so the OB providers can be informed and ready to do their part. We had an improving postpartum access to care fact sheet. This was really our why sheet. Why do this work? Why is it important? And then as well as other why tools, including ACOG guidance. And in Illinois, we have a maternal morbidity and mortality report that's done every couple of years based on the Maternal Mortality Review Committee that really made it evident the importance of that early postpartum period in maternal deaths. We also included a Medicaid provider notice. This has been updated since we started. I'll talk more about it later, but now our Medicaid in Illinois covers the 2 postpartum visits, and we'll talk about that. And then other provider education resources and a flyer that it's a simple visual that we'll see soon that helps them know what the maternal health safety check and the early postpartum visits all about. So, well, I said we'd talk about it later, and here we are already at later. So during our IPAC initiative, we worked with hospital teams and the state Medicaid members of our leadership team to develop processes for facilitating billing for an additional early postpartum visit, in addition to the traditional 6-week visit. While at the same time, so we kind of worked with what we had during the initiative and worked to provide guidance with our Medicaid office to our hospital teams for billing. At the same time, we do this with many of our initiatives. We concurrently were working with our Medicaid leader colleagues to build a case for change to Medicaid policy to explicitly cover 2 postpartum visits. And this work of the collaborative contributed actually to the state Medicaid policy changing at the end of last year and reflected in this provider notice here. So, the punchline is that it explicitly outlines the coverage of 2 visits. And so that's, again, an example of we're always improving, always changing, and the initiative now has another tool for providers through billing. So other key tools to help clinical teams activate early postpartum visits, specifically the providers, is on the right, a flyer. This is that office flyer that we shared, just reminding providers about the importance of asking patients to schedule a 2-week postpartum visit, and then what as a provider to do on that postpartum visit, which is really, we have a nice tool on the left to make sure that they can do that using a checklist. It has all the points there. So now we're going to move on to education on postpartum safety for patients, as well as strategies and tools developed to help hospital teams engage patients in 3 main points. And I've mentioned these, but I'll reiterate them. When we talked about, IPAC patient education, it included benefits of the early postpartum visit, making sure patients were aware of early warning signs and how and where to seek help and care if they need it, if they have warning signs, and then the benefits of pregnancy spacing and what their family planning options are. So the percent of patients, again, we've started each of these sections with data. So I just wanted to show you what we were able to accomplish before I got into the strategies. This is what we did, and I'll get to the how. But here is a graph of a process measure on patient education. Percent of patients receiving standardized education on benefits of early postpartum visits, early warning signs, and birth spacing over the course of the initiative. And it increased from no education happening on some of these topics, with the exception of early warning signs, with a lot of work with AWON and other groups had been starting to happen before the start of this initiative, and increased to 90% across those topics by the end of the initiative. So I promised more hospital team wisdom, which is far greater than mine. And we did learn from the hospital teams that I shared some of their stories about how they implemented this work earlier, that they had some specific education strategies that worked for them. And so with one hospital, all patients received postpartum education in a discharge booklet with their standardized education on admission to the postpartum. And education was provided by the nurse. And another hospital that had the patient navigator, this was the second hospital I shared, that patient navigator also helped with the education. So a couple different strategies used there. So how did hospital teams do this work? Again, I can't emphasize enough how with this kind of implementation work, a process flow is an excellent tool. Not only is it a tool for direct clinical decision-making and work, but it's also clinical process decisions and steps, as well as a really great QI tool to build PDSA cycles on, and tests of change, and really understanding what works and what doesn't. So we worked with them to process map their current postpartum discharge and look at opportunities to integrate this postpartum safety education, as well as the scheduling of the early postpartum visit into that process. So this is an example that we shared with our hospital teams. It includes the roles and tasks of the clinical team and other staff involved. So other key tools we developed or disseminated from existing sources to help clinical teams activate their patient education for IPAC were several flyers. And these were covering the 3 topics. We really tried to synthesize into individual resources versus have multiple resources on each topic, given that there were already 3 topics. So, from left to right, importance of early postpartum visits. We created this tool based on input from our hospital teams, healthy pregnancy spacing, and then post-birth warning signs. I'm sure many of you have seen that before. It's an AWON tool. The central one is March of Dimes. We also provided support to hospital teams who needed to adapt those tools a little bit to meet their needs. So other tools for patient education on urgent maternal warning signs, came through, were kind of being developed as we were doing this work, and we are sharing them here. We kept adding things that were helpful to teams that teams were using. And this is really focused on early maternal warning signs, more on that, which I think came a lot of resources came out of the Hear Her campaign, and these are 3 from that. And they also kind of help patients think about how to engage their care providers, friends, and family to help them in acting on any warning signs. They're all pictured here. So I think, one thing that was important throughout this initiative is really to make it clear the different team players' roles in the process of improving postpartum access to care, scheduling an early postpartum visit, and educating patients and providers and nurses. I think that, this is really at the heart of it. So I wanted to go into it a little bit more about how we define those roles. So first, the role of the OB provider, and it included that they do several things. One is counsel all patients on the plan for an early postpartum visit and why it's important, and that it needs to happen within 2 weeks, which is what we focused on for our initiative. They also, their role is to discuss key aspects and components of the visit so the patient could really understand what it was about, and then to document that discussion and plan. The second is to ensure that the patient receives postpartum education material before discharge on the topics we've been discussing. Next is to facilitate the scheduling of the early postpartum visit within 2 weeks for all patients and document that in the chart. And then they also confirm that patients receive the early postpartum visit within 2 weeks and have that maternal health safety check. And as the provider, they're using the checklist to make sure that all the important components are addressed. And then finally, documenting and billing for that early postpartum visit. On the nursing side, the role involves that they understand the maternal risks in the postpartum period and the benefits of the early postpartum visit and the maternal health safety check. It also means that they ensure patients receive postpartum education material before discharge. They facilitate and help ensure scheduling early postpartum visits within 2 weeks for all patients before hospital discharge, and confirm that it's documented both in the chart and that in discharge instructions. And then finally, they facilitate discharge conversations and ensure patient understanding of the key postpartum education materials, their plan for an early postpartum visit, and that they have that appointment scheduled. So the IPAC initiative moved to sustainability in 2020 in Illinois, but the work does continue. We work with all of our hospital teams across initiatives specific to each initiative to develop a sustainability plan that includes compliance monitoring and scheduling, monitoring the scheduling of the visits, and that provider billing is happening to make sure it's a sustainable approach. And then new hire education and ongoing clinician education. The strategy from one of the hospital teams we heard from earlier was to randomly select charts for a quarterly audit to monitor their compliance with the initiative aims and billing, and identify opportunities for feedback and education to the clinical team. So again, teams develop these plans, aware of their resources and their processes, and make it happen to make sure that this work continues. And then another thing I'm really excited about is that we have another initiative that started summer of 2021 called the Birth Equity Initiative. And this work is so important that we incorporate, and so relevant to birth equity, that we incorporated basically the IPAC initiative as a strategy in the Birth Equity Initiative. And this helps us engage more birthing hospitals in this important work. So we have 86 hospital teams, the majority of our hospitals in the state, participating in this. And they're working to standardize postpartum safety and education and schedule early postpartum visits as part of their birth equity strategies. So one of our hospital teams that participated in IPAC and is now actively involved in the Birth Equity Initiative just kind of emphasized, I think, a lot of good themes that have come up in nice plain language. So part of the challenge, the biggest culture change implementing this work in birth equity is getting away from the perception that patients fine and that 6 weeks is okay to see them. And instead, changing that culture and thinking among the clinical team. And then having at the ready the resources, statistics, education that they need to help have those conversations with the clinical team and providers to understand how this work helps keep women safe and improves birth equity. So there are even more resources now in this area than there were a couple of years ago when we did the work. I did want to make sure you knew that we do have our IPAC toolkit online, as with all of our toolkits. Resources are completely available to you. I encourage you to take a look at them. And we have a lot of great stuff on there, especially the provider packet, which deals with buy-in and implementation, and billing, all the aspects. And then our education tools and patient education resources that we created and that we share that somebody else created, as well as AIM. AIM, I was a part of the group that reviewed and updated the AIM postpartum discharge transition bundle. And so there are some great resources in there, and certainly the oomph and endorsement and support that having an AIM bundle gives to the importance of this work, and really encouraging. This one deals with making sure that it's a little bit broader than just within what our Improving Postpartum Access to Care initiative was, but it has great additional resources as well. And that is it for me today. I do hope that this information was helpful and that your meeting is a great success. And I look forward to checking in with FPQC and learning more about what you've been able to accomplish together in the future. Thank you so much.